It is just a huge honor for me today to be podcast interviewing Dr. Seena Patel, DMD, MPH. Thank you so much for coming over today. She currently serves as the Associate Director of Oral Medicine and Associate Professor at the Arizona School of Dentistry and Oral Health at A.T. Still University. She is also an associate at Southwest Orofacial Group in Phoenix, Arizona, limiting her practice to orofacial pain, oral medicine, and dental sleep medicine since 2012. She is a diplomate of both the American Board of Orofacial Pain and the American Board of Oral Medicine. Dr. Patel simultaneously earned her dental and master's in public health degrees from the Arizona School of Dentistry and Oral Health in 2010 and completed a 2-year residency in both orofacial pain and oral medicine at the Herman Ostrow School of Dentistry at the University of Southern California. Her educational interests are in myofascial pain, head and neck cancer and dental management, oral mucosal diseases, management of obstructive sleep apnea with mandibular advancement devices, and the dental management of medically complex patients. She has authored numerous publications and abstracts and serves as a reviewer of several peer-reviewed dental journals. Furthermore, she has spoken nationally and internationally on orofacial pain, oral mucosal diseases, dental sleep medicine, and the dental management of head and neck cancer, and has given over 50 professional continuing education courses. She maintains her membership in the American Academy of Orofacial Pain, American Academy of Oral Medicine, Central Arizona Dental Society, the ADA, the list goes on, and the Special Care in Dentistry Association. Thank you so much for coming on the show today.
Thank you. Thanks for having me.
And thank you so much. On Dental Town Magazine, you've done 2 articles for us. Name That Oral Lesion. You did that in 2017 and 2019, and I'm so proud that I didn't get any of them right. But my gosh, and I have to thank you. The story is when I got out of school in '87 and came to Phoenix, I got a job as an associate with your dad.
Yes.
And Dr. Nick Gidwani, and the joke was back at the time that I would pull the top half of the tooth out, and then after I gave up, I would go get your dad or Nick, and they would pull out the bottom half. So I want to thank again your father for all the oral surgery that he taught me. It was amazing. I was doing my dental school, all my dental school requirements. I was doing them once a week where we worked at Sunshine Dental. I mean,
wow.
if you looked at your, it's 56 fillings. I think we had to do 55 fillings and extract 15 teeth. That was a slow week at Sunshine. You did. So yeah. I loved it. I mean, I just could not believe that I was doubling my requirements every week. And I felt fearless because I had guys like your dad and Nick that I knew all I had to do was, try anything. And if you couldn't do it, your dad or Nick would come get me. But so how did you, how did you end up in this specialty as opposed to general dentistry?
Oh, well, that's a good question. It certainly wasn't a decision I had going into dental school. I was pretty young when I started, and I knew I liked dentistry, but there's a whole world of different specialties you can get into. And I want to say around 3rd and 4th year, I really enjoyed surgery and medically complex patients. One thing I realized by the time I was a 4th year was that having the confidence in treating really complex patients and really knowing the connection between medicine and dentistry, I felt kind of weak. So then I actually paired up with a very good, well-known faculty of mine, Dr. Michael Glick. He was one of the faculty at the dental school I was at back in 2010, and I thereby got interested in oral medicine. And so I thought, okay, actually this seems to be a better fit for me, and one thing led to another. I ended up at the dual orofacial pain program at University of Southern California under Dr. Glenn Clark, and that's really what exposed me to this. So I will say the decision to enter this field was almost on accident, I like to tell people, but I will say it was the best thing that ever happened to me because it opened a whole new aspect of dentistry I never knew about.
There's a lot of controversy on Dental Town where whenever they're talking about making it a specialty.
Sure.
And I guess they've been applying for different groups have been applying for a specialty as long as I've been a dentist. What are your thoughts on the controversy making it a specialty, especially in light of the state of Texas said, well, that's the American Dental Association is not a government agency. It's they just don't want you to truth in advertising. They don't want you to say you're an implantologist if you're not. But it's kind of what do you think about all those thoughts?
It's hard, there's, like you said, it is a controversy, but the reality is that these fields have evolved significantly in the last few decades. They are evidence-based, university-based, CODA-accredited programs that are out there to train providers. And the other thing is that there are so many conditions that are missed because if our specialty, I'll use that in quotes because, as you know, of course, it's not an ADA recognized specialty yet, but if we don't have providers limiting their practice to these conditions, then it dilutes the field a little bit, and it doesn't allow patients to get to the right provider. So unfortunately, what I've seen in my practice and at the dental school where we teach, people end up seeing many different providers and not really getting the right diagnosis or care they need. So if we don't highlight and develop this field as a specialty, we do lose out on that. Now, the controversy lies in the fact that especially in the world of oral facial pain, there's just been a lot of change in terms of diagnosis and treatment over the years. So you have a few different academies, I suppose, who maybe have different schools of thought. And I can't speak to each individual on that, but our academies in the Academy of Oral Facial Pain. So those are university-based programs, and they are 2-year CODA accredited programs that train professionals. So it really needs to be done, and it's about time that happens. So we can only help but support that. And both academies, oral medicine and oral facial pain, have applied, like you mentioned. So
it seems so easy to solve because it should be patient-centric.
Exactly.
And
100%.
And the patient shouldn't have to figure all this stuff out. And
Yep.
And I mean, my gosh, if I was having one part of my body having a problem, I would want to go to specialize in that. I don't see why a dentist's turf or business or practice has anything to do with a patient-centric model. Why is it not so obvious?
Well, I'm not sure I have a good answer to that. What my thoughts are probably is that in certain aspects of the field, there may be overlap in terms of what some of the conditions treated. They overlap in different dental specialties. That might be one thing. In certain pain-related conditions, like I said, decades ago, we thought, TMJ-related pain was due to occlusion. And then there were different kinds of treatments for that. And it kept evolving over time. And these differences they haven't been accepted by the community at large because of these different organizations that keep supporting different treatments. So when you have this diversity, that leads to more controversy, and it just takes a greater fight for one organization to say, hey, this is the governing body for that field, and to move it forward. So we're kind of just lingering in this, unfortunately, what seems to be kind of like a turf war, but probably just a lack of consensus on what everybody wants to do about it. So it is changing, though. I mean, I've seen so much positive evolution of this field in my short lifetime in the field, so I can only imagine it's going to get better.
Well, the kids, I feel sorry for the kids, and you spend a lot of time at HE still in a dental school, so you're around the students with a lot of amazing professors like Tim Lukowski, Tim Taylor, just a lot of great people there. But they seem to report on Dental Town a lot, or to me, that they don't see a lot of big controversies among the endodontist or the oral surgeons or the periodontists. But when it gets to TMJ and occlusion, they describe it as like there's a plethora of world religions.
That's how I feel too, I honestly. And the way I was trained, we've always been evidence-based. So we're very strict. All the university-based programs teach you, go back to the evidence. But I will still say it's so difficult to argue this subject with someone who might have been trained differently. I mean, I've gone to excellent symposiums, conferences, and talked to very educated people who want to help their patients too. But the philosophy there, it's really like talking about religion. And if we keep it at that mindset, we won't be able to move further. So that's what makes it difficult. And I can't say I have figured out a good solution to that. Maybe we both have to keep an open mind.
So So, what is oral facial pain, oral medicine, dental sleep medicine? What is your world like?
Yeah. So orofacial pain is a discipline that involves basically the pain management of any condition going from the neck up. So that includes neuropathic disorders like trigeminal neuralgia, post-traumatic trigeminal neuropathy, or what was previously known as atypical odontalgia or phantom tooth pain, myofascial pain, myogenous disorders, TMDs, which we would classify as joint disorders like clicking, popping, arthritis, or myofascial pain, masticatory myalgia. Most people will think of it as muscle pain due to bruxism or clenching, grinding, stress-related conditions. But this field also includes the management of headache-related conditions that tie into the orofacial or maxillofacial region. So that could include migraine, cervicogenic headache. It's amazing how many of these neurological conditions are actually triggered by the maxillofacial complex. So it is, I mean, every day I'm amazed at, treating people and all the different things we see because it's a pretty diverse field. So then from orofacial pain ties into sleep. As we know, pain and sleep are so interconnected. So the field of dental sleep medicine, it's newer, but the role of the dentist has really evolved in terms of helping to maintain a patient's overall health, screening for severe health consequences like sleep apnea we know can contribute to cardiovascular disease, cognitive dysfunction. I'm drawing kind of another blank here, but amongst a whole host of other sequelae. So, and then we can also play a role in insomnia and just getting the patient to the right provider so that they can be diagnosed sooner rather than later. But our main role famously is known for making oral appliances for sleep apnea. So that's dental sleep medicine. But even that, we have an expansion of our role as a dentist to play in these fields.
So, a lot of people believe that, a general dentist teaches three diseases, perio, cario, and occlusion, Do they have one that rhymes with perio, cario? Is there an occlusion word that rhymes with that? But not to throw my homies under a bridge, I love them to death. But in most practices, if you come in and you said any one of those symptoms, my teeth, I'm grinding, whatever, they just call in the front desk, see if their insurance covers a night guard. If it says yes, the assistants come in, take impressions. That's TMJ for 9 out of 10 dental offices in America. It's just alginates, a bite plane. What do you think of that?
I think we're jumping to symptom management rather than going back to really assess what the diagnosis is for the patient. And that's what I strive to teach others too, is let's go back to what the patient reports. Let's get an adequate history. Let's actually figure out what we're treating before we jump to treatments. But I think as dentists, we're almost trained that way because it's a surgical, mechanical field. So I like to take a step back to go back and say, okay, what are we actually treating before we just, prescribe a night guard or something like that. There's so many other treatments that can be done.
And I know a big, a lot of people always wonder how much of this is psychosomatic. Like,
sure,
you see someone grinding their teeth, but they're going through a divorce, and they the kid crashed the car, and whatever. How much of this is stress versus mechanical?
So that's a really good question, because you're right. Historically, the pain-related complaints have always been kind of thrown under, like maybe you're just stressed or you're anxious or depressed or something like that. Well, pain in general, we know, is associated with psychiatric comorbidities. There's no doubt about that. Someone in chronic pain may develop anxiety or depression. It's just difficult to figure out which came first. But the problem is stress, as we know it, causes almost every disease on the planet. So there, absolutely, we carry tension in our muscles, and we might stress out because of a certain situation in our lives. But what we've known is that direct cause and effect relationship to grinding your teeth or bruxism is not completely proven. We know that bruxism is actually a sleep disorder. Probably 80% of the population grinds their teeth at night and is asymptomatic. So to just label grinding your teeth, you must be stressed, it's overstated, in my opinion. So we have to look back to see, is this a motor disorder or is there some inflammatory component to the TMJ? Certainly, if you develop myofascial pain, it's a vicious feedback cycle. You get a trigger point or a tight knot. It tells your brain, I'm in pain. Your brain's going to say, okay, the muscle's going to tighten more. And it just keeps looping. So Chronic pain is a whole different entity. We have to look at it very differently than looking at just mechanics. And I think that's where we as dentists forget that if we're just looking at a click or a pop or an arthritic joint, has it turned into chronic pain, which is a central nervous system disorder, or is there a mechanical issue? That's where we face difficulty with treatments. So we try to fix the problem. Whereas with chronic pain, we have to shift our focus to management.
I just made the most unique observation for me in 57 years. I caught my dog grinding his teeth while he slept.
Oh.
And I never even thought these
Yeah.
dogs grind their teeth, but I'm sitting there in my chair like, okay, he's grinding his teeth. So Bambi, she was definitely grinding her teeth. We'll have to consult others for that. Dental sleep medicine, when your father and I got out of school, it was never mentioned. Now it's all the rage. How did it go from didn't exist to now everyone's talking about it?
Sleep medicine, even in itself within medicine, is new. But what they found was, I believe it was decades ago. I forget the exact year, but a physician was trying to treat his own sleep breathing issues by pulling his tongue forward and managing it that way. So that kind of sparked the whole concept of oral appliances, or repositioning the mandible or repositioning the tongue in some way to open up the airway. And so that's where dentists found their kind of niche into that field. But in addition, even when we're looking at kids too, as they grow, we realize there are skeletal issues that can happen in the maxillofacial complex that can affect a kid's growth and potentially affect the airway or vice versa. So all these things kind of came together, and that's how we found our role. And now, you're right, oral appliances are a big thing, and it's another avenue where a dentist can provide care for a patient. But more importantly, if we look at the big picture, it's us helping in the overall health of the patient. So there's greater motor vehicle accidents, there's cognitive dysfunction, memory loss, mood disorders, all kinds of things tied into poor sleep. So if we can help screen for those, that's a pretty big thing. I mean, patients visit dentists more often than their own physician. So if we can get that conversation going, there's simple tools you can teach yourself and really incorporate that. So that's kind of how it started and became a big thing now.
Do you think dental sleep medicine should be a part of every general dentist practice?
Yeah, absolutely. It's still a discipline of dentistry. And if we're looking at the role of general dentistry, we should be screening for these things. We now teach people to screen for TMJ disorders or oral pathological conditions. So there's no reason that sleep shouldn't be included as well.
And do you think they're doing it well, or there's a lot of...
I think that there's a really good effort, but you're right. I do feel that from a big picture standpoint, we do need more education and a little bit more time spent in more of the academic or university-based, evidence-based programs. Sometimes we're really quick to jump because we're busy people. We don't have a lot of time, so it's easy to try to take a quick course or something on that. But we just need to start with the basics, start with diagnostics first, learn what dental sleep medicine is all about before we jump into oral appliances.
Does this mean you'll be making an online course for Dental Town?
Oh, yeah.
I would love that. Talk about your special research projects of head and neck cancer patients, particularly HPV and oropharyngeal cancer.
Yeah, well, HPV and oropharyngeal cancer is a hot topic. I mean, if we look at the literature, there's probably something every month coming out new in the dental literature. What's really fascinating is just what I was taught in 2006. Fast forward 10 years later, and we're taught the exact opposite about this virus. But just like those other conditions we talked about where dentists can play a role in helping the overall health of the patient, same thing here. We should be asking training our providers to discuss whether a patient has received the HPV vaccine for prevention of HPV-related oropharyngeal cancers. So one of my research projects actually, I collaborated with some other faculty, so Dr. Ann Spolarich, Dr. Maureen Perry, and Dr. Alexis Koskin. She's a public health specialist at ASU. We surveyed our Arizona dental population, dental providers, so hygienists and dentists at the Western Regional Dental Convention last year to see, hey, how many of you are interested in this subject? What do you know about this subject? Are you willing to talk to your patients? Because some people find it to be sensitive, or would you change some practices based on more training? So we got, a really positive response overall, but there are still knowledge gaps. So we need to improve on those. So that's something we're working on, developing training modules. And on the other hand, we've got another trial going on with head and neck cancer patients going through radiation, and we're doing fluoride application methods. So traditionally, patients are prescribed fluoride trays because they're going to get dry mouth from the radiation, and that's a lifelong treatment. The problem is compliance with that is poor. The trays can sometimes cause pain in the tissues during radiation because your mouth tissues are so dry. It frankly hurts, and I've seen that. My patients go through that, so I can empathize a little bit more now having seen that. So we feel that brushing it on is perfectly acceptable, and it works just as well. So we're doing a trial on that. But amongst this process, I've seen all these complications happen in patients in terms of pain, neuropathic pain, musculoskeletal pain, limited mouth opening, mouth ulcers. It's a tough process. So I guess I just found a little excitement in working with these patients who are just going through a tough time with treatment.
The thing that, I mean, just to be honest, I'm not a big fan of any government. Not a government fan. I am 57 years old, born in this country. I cannot go buy the HPV vaccine for me. I mean, I've gone to Walgreens. I talked to my pharmacist. The lady who I bought the house from had to sell this house and move to Scandinavia because she had brain cancer, and the company that made the drug was selling it in Scandinavia, but wasn't legal in the United States. And I just thought, how insulting that a government agency won't let a dying American buy a drug. And here, the HPV vaccine, I want to be able to tell my patients, I mean, I've taken it, but I cannot take it because the powers that be that people surrender to have decided that I can't purchase it. I mean, it's just. I mean, guys. I mean, I don't even know where to start. People's. It's like government is the problem. It's never the solution. Yet everybody runs to the government like it's their mom. Mom, what should we do? Well, first of all, quit asking that person. But I know my dentists, and so many of them are conservative Christians, and they're just not going to bring up HPV, oral sex. So, how are you a doctor when your patient is a mammal that gives birth to live young, nurses their young? I mean, why is this such an issue to talk about HPV, oral cancer, oral sex? I mean, what are your thoughts on that?
Yeah, I agree. That's
and is it different? Is it a generation thing? Like, are you different about your views on this than you say your father, who's my age? I mean,
yeah. Well, certainly the generation we're raised and born in, the culture, society, all of these impact our views on things. Unfortunately, we have access, fortunately or unfortunately, we have access to so many different sources of media, so we can get good information, we can get equally bad information, and one important person says one thing and it runs like wildfire. Whether that's good or bad, I don't, that's the issue that arises. My personal thoughts are, I'll be very honest, the first version of the HPV vaccine came out in 2006. I was a first-year dental student. I was 20. And all my friends who were going into medicine, they're all telling me, should we get it? Should we not get it? All these things. And I, too, thought the same conservative way that, do I really need it? Is that only for certain, populations, this and that? And now having gone through this program where I'm starting to get involved in the subject, the research, I just realized how wrong I was. It really has nothing to do with that. It's just a stigma like anything else our society places on things. We have to look at it as a cancer prevention tool. So it's not looking at it as it preventing. Don't even look at it as an STI. Look at it as this is something that causes cancer. We are preventing cancer. And when we look at it and market it that way, people will change their minds. We can only do what we can, recommend it, and
where did you go to college at? Where was undergrad?
University of Arizona.
U of A.
Yeah.
So U of A, you might not have needed an HPV vaccine. It's ASU, where you should be, you should get it at the door. I think we can all agree on that. But anyway, the one thing I've noticed the most in my life is the losing of trust by American people, and it was before the internet. I mean. Like when people are talking about an election, I mean, do congressmen realize they only have an 11% approval rating? And then the news media, who's always playing war with the politicians, they have the same rating. And it's kind of been my entire 57-year experience is that all the institutions have been losing trust My tool just are Catholic nuns. I mean, the Catholic Church Trust has been plummeting. So when you talk about vaccines, I mean, I cannot go to any family function, any party or whatever with strong anti-vaxxers there. And when you listen to them, you just realize that what they've lost is that they lost faith, they've lost trust, and they don't know who to believe anymore. Yeah. So fake news is kind of a sad state of affairs, that something is taking trust and faith from basic institutions away from everyday people. Do you see that? Or
Absolutely. I mean, if I'm just speaking to our own industry, I mean, how much access do patients have to look up stuff about diseases and dental disease and medical disease beforehand? Then you go to the doctor and you question a bunch of things. I mean, I think every provider I know has shown frustration being on our side of it, and how much you face just being a provider to a patient because of the fear. And I can't blame them, because if I flip the situation, I'm fearful too. You know, we have all these fears about, medicines, treatments. Am I getting the right treatment? Is somebody trying to do something I don't need? There's all that out there. So it's not the days where you just blindly trusted anybody, much less your own doctor. I don't know.
Yeah,
that's just our current situation.
And also, you can't anticipate why. Like I've only really been involved public issues on the water fluoridation. I helped got it in '89, and then when it expired 20 years later. And a lot of people just come up to me and say, I don't care if what you're saying is true or false. I just don't want the government touching my water. I don't want, it's like the minute you tell them the government's doing something, and like I completely I get where that's coming from. But I think 1/4 of Arizona, you could never change your mind about water fluoridation, which I'm fine with. Do you think the HPV vaccine, what percent of the kids that should be getting it are getting it right now?
The statistics in Arizona are around the upper 40%. So I have the numbers in my computer, but it's around 46%. The challenge is we need to get the rate a little bit higher for boys. That's been a newer issue lately. Of course, when this vaccine first came out, it was targeted towards girls, and now we know that they both equally need it. So, but we're about 46%. We're still low. I mean, healthy people 2020 wants 80% by 2020. So that's in 2 months.
What's interesting is when the herd starts to get vaccinated, it starts helping the non-vaccinated herd.
Yep, absolutely. That's what they want to reach, is herd immunity. So it's education. That's the whole point of getting any vaccine, is to achieve herd immunity, so that even people who aren't vaccinated are benefited by that.
So, a lot of kids, they focus a lot more when they have skin in the game and they have to buy something expensive. When you start getting into your field, is there expensive equipment that is worth buying? Is there stuff that you need to do your job?
In orofacial pain?
Mm-hmm.
That's actually the kind of cool thing, is in orofacial pain and oral medicine, I wouldn't say there's expensive equipment. Probably the most expensive is our imaging modality, which is the CBCT machine. That is very necessary to our practice, but that's probably the most expensive. In terms of everything else, you have the tools that in your practice.
There are some big companies that cater to your field. Myotronics,
sure.
And I think they sell a lot of $10,000 or $15,000 machines. Do you see any of those as necessary, or?
I really don't.
You really don't?
I really don't. No, those, again, that always brings me back to, when I teach my students, the same thing, is when you're looking at orofacial pain providers, like go back to or if you're going for CE courses, look at what's tied to the American Academy of Orofacial Pain. That's evidence-based. And a lot of the other expensive equipment simply haven't been proven to be any better than our traditional tools we have in our office. So I don't use them myself, those other things that you mentioned.
All joking aside, trigger points. The word neuromuscular is a trigger point for a lot of people. You say neuromuscular, and some immediately go defensive or.
That's true. That's true.
So why is neuromuscular a trigger word?
So, and I don't, having been, I guess, being newer in the field, I didn't get to personally experience all the evolution that orofacial pain has come through. So I didn't get to firsthand see the full mouth rehabs that were going to happen and all these other different modalities of treatment. So just from reading and speaking with colleagues and other experts, neuromuscular dentistry is a term for providers out there who supposedly are trained to find the appropriate occlusion that's supposed to completely manage a pain-related complaint. I'm sure there are specifics to the process of how they get to a diagnosis or treatment, but traditionally, once they have that position, the occlusion is altered by irreversible treatment modalities. So the reason we get so defensive and tight when we hear that term is because it's not evidence-based, and irreversible therapy is not the first line of treatment that even the ADA standard guidelines dictate for orofacial pain disorders. The first line of treatment is conservative therapy, so reversible treatment modalities. So when we see that that becomes the first thing, we do get a little defensive about that.
And some of these occlusion camps, it seems like a lot of, after all their workup, means that you need to redo all your teeth.
Yeah.
So that's not very conservative.
Nope, that's irreversible treatment. It's not first line.
But is that kind of what you're alluding to? That
yes.
some of these people, they have a course, they show what's wrong, they have all this equipment, and when you're whole done, the treatment plan is always the same.
Right.
Around 28 teeth in your mouth.
Yeah, I still get shocked to see that. Now, I think that the providers trained in that's wherever the education came from, they're trying to help their patients. So I respect that. I really do, because they're trying to learn more and they're trying to do the right thing. Unfortunately, it's just not evidence-based, and so we see these procedures that don't need to be done.
And I'll call. You're more sweet than I am,
Probably.
or I'm more jaded. But I mean, we saw this with the anti-mercury guys, the Hal Huggins guys. It's like, okay,
right, yeah.
Okay, I don't agree with any of your science about your mercury. But even when you did the treatment plan, replacing all the amalgams in their head, I mean, you charge $30,000. I mean,
true.
Even if I believed all your voodoo,
I know
I could have fixed them up for maybe $1,500 or $3,000. But it was always all this voodoo medicine. But then the treatment plan again was always like $30,000.
That's true.
By someone who would do anything to get rid of her MS or her disease or whatever. And it's like, so if I would have seen a hint of this where you believe all this stuff and it's from the goodness of your heart, but could we do this for $1,500 or $5,000? But
is true. That is true.
Is it always come to the amount of a treatment plan that none of my alcoholic dentist friends have ever done in the last 5 years? I mean, so there's a lot of
you're
red.
right. Yeah.
There's a lot of red flags.
There are a lot of red flags. I mean, there's a whole host of things that are like, okay, you're right. It seems to be the same treatment plan. That it's irreversible. There's a cost. We can definitely make the reversible treatments that work, that are evidence-based, they work effectively, they are much less costly too. That is for sure.
Yeah, and I mean, my mom and dad had 7 kids in I think 3.5 hours. They were Catholic, and okay. So there's just a lot of people that don't have the money,
right? Exactly.
For a $30,000 solution if someone else can do it for less. You say your favorite procedures are trigger point injections, occipital nerve blocks, and biopsies, and I bet 99% of the dentists have never done any of those 3 things. So, what are those 3 things, and why are they your favorite procedures?
So there's a few things. One, I think the fact that most people haven't done those things may be why I like them so much too. It makes me feel a little unique. But no, trigger point injections fascinate me every time I do that. Anytime I can get rid of a certain pain complaint that seems to be coming from a distant site, for example, a toothache, and then I injected the masseter muscle or even some of the cervical muscles and it disappears, I'm in awe that our body works this way. So I guess it makes me feel so good that I can immediately give someone pain relief. Even though trigger point injection, I always explain to people, it's an adjunct to treatment. It's not a cure by any means, and it's a great diagnostic test. But I love that we can use a conservative, non-medication approach because we use lidocaine, but that's it. It's really the physical needling technique of that injection that works. It's so safe, and that's one of the things. I always see such great instant relief from it. So I love that about my field. Same with occipital nerve blocks. You have a patient with a migraine, try an occipital nerve block, and it brings it right away. You just gave that patient their day back. I had a student who came to me with a complaint like that, and we did that they're just so grateful, and it makes me feel good. So I guess it's a little selfish as to why I like that procedure so much. And then biopsies, oral pathology is just such a fun area for me. So it lets me kind of hang on to some of that surgical technique that I'm now in a field that's less procedural. But I like I mentioned before, I kind of wanted to be a surgeon at one point in my life. And so I like to hang on to those procedural skills. And this always kind of fulfills that for me. So I like doing that.
So now, are these things that general dentists could do?
Absolutely. Yeah, I don't see why not. The key thing is learn what you're treating, learn how to diagnose it. And the procedure is always easy to follow.
Huh, that is amazing. And so is there a Delta Dental of Arizona code for this at your office in Phoenix, Arizona? Because you're at the dental school,
yeah.
And you're also at Southwest Orofacial Group. That's in Cave Creek?
We have 3 locations. It's in North Phoenix, Peoria, and Tempe.
Oh, you have one in Tempe?
Yeah.
Oh,
yeah, not too far from here.
I was not aware of that. Where's the one in Tempe?
By 101 in Southern.
101 in Southern, really? And is that the one you work at?
No, I actually work out of the one on Cave Creek Greenway, which is in North Phoenix.
And then you also work at AT
Yeah,
still.
So I'm going 1 hour each way.
You should probably work at the Tempe location and then buy a house in the middle.
Yeah.
So what are you doing at Southwest Orofacial Group, and are all these things insurance driven? I mean, does Delta pay for all that, or is this medical insurance, or is this cash, or but specifically back to these trigger point injections?
Sure. So the practice I work at, I actually joined Dr. Rich Cohen's practice. He previously owned it, and I've been with it for 7 years, and it is completely, we're contracted with medical insurance only. So we are unique in that we're probably fewer providers who do that. So that's kind of a whole different ballgame. So they are covered through medical insurance, but we do work with some experts in billing to understand the game of that, but we do get very good coverage, so our patients get that service. When as far as like Delta Dental, I can't really speak to that. I'm not sure if dental insurance covers these. I haven't worked with that because at the school we also use medical insurance.
So does Richard Cohen does he still own that?
He doesn't own it, but he still works with it. Yeah,
he still
did sell it. Yeah.
He was. I'll tell you what. When I got here in '87, he was already the leader in that.
Yeah, he's
and
great.
When he was the leader in that in 87, when I got here, he was the number one guy in Phoenix doing that. And back then, I mean, a lot of dentists didn't even believe in it.
Yeah,
sure. And they I mean, we're seriously, when I got here in '87, you referred to Joseph Cohen if you had, quote, a crazy lady. And they would talk in a lecture. You know when they have crazy eyes and they're saying crazy things? Yeah, that's when you send them to Joe. TMJ is something crazy.
You're right though. Yeah,
I'm telling you, I'm confessing to you. That's how that field started. And
it's true.
In 32 years, it's gone from the crazy lady with crazy eyes disease to now look at it. I mean,
that it's actually a disease. Yeah, exactly. I completely agree.
And it's one of the reasons the all male gynecologists are now all women, because they used to say you're being hysterical, which is the Greek word for uterus. I mean, you can imagine. Could you imagine that you tell somebody and they say, "Oh, you're acting like a bunch of testicles," And so people weren't listening to. The male gynecologists weren't listening to. I know the male dentists weren't listening to TMJ in '87.
Right.
You were a crazy lady, and we could diagnose it by your crazy eyes. And now,
look at it now.
So do you? So that question is: do you see more female patients? Is this a more female disease?
It certainly is. Pain in general affects women more, and there's a whole host of just gender-related genetic differences that allow for that. I mean, that's a whole different realm of study, but we do know that there's hormonal related changes that play into chronic pain, different kinds of joint disorders, things like that. So I'd say it's probably 3-to-1, just like migraine is 3-to-1 female to male. Probably that's about a good ratio for my practice too.
So when we said in '87 it was a crazy lady disease, we were partly right. It was definitely a lady disease. Right?
For the most part, it is absolutely
3-to-1 in migraines, and
yes.
3-to-1 in what else?
Well, I would say oral-facial pain in general, like pain.
It's 3 to 1.
It's definitely it affects women more. That's hands down truth.
You know, that's why I only had 4 boys. I did not have
Aren't you lucky?
any women because of just that. I specifically tried. What is the low-hanging fruit on why it's women 3 to 1?
Well, it just goes back to the actually genetic differences in terms of our hormone levels. So we know that there's a hormonal component to pain, and differences in estrogen levels, things like that, they predispose you to chronic pain and also persist certain pain disorders. I can't speak to the exact mechanism, but that's really where it ties into, and they have studied that, they see that. So,
but one of the things, being a man, one of the trends I've seen on a lot of diseases that are more for women than the men.
Sure.
A lot of times over the years, I've seen a pattern where men have a problem of underreporting, under raising their hand that they have a problem, and that a lot of boys they just don't get help. I mean, it's hard to get them to ask for directions.
Yeah, that is true.
So do you think this 3 to 1 is more because some part of it might be the fact that women are more likely to raise their hand and seek help, and boys don't?
That might be true. In general, women go to the physician or dentist more because they're more proactive about seeing the doctor rather than men. That's pretty well known. So I think that's part of it. But there are actually large population-based studies that have all over the world on migraine at least, and they've really seen that consistent 3 to 1. I don't know what the ratio is exactly for TMJ-related disorders or other pain disorders, but I don't think that that's the only issue, is that men are not forthcoming in terms of their symptoms and not coming into the office. That might be a tiny part of it, maybe 5% if I'm just going to throw a number out there. But I think there really are just differences in how a woman's body and a man's body respond to pain.
I always tell dentists, I don't care if your clinical dentistry is an A, B, or C. I just want your diagnosis to be an A.
Exactly.
I just think the diagnosis is so much more important than the treatment. Yeah. Just spend more time. What do you think dentists could do to be better at diagnostic?
Taking a better history. I always teach everyone 90% of what you need to know is coming from the history, and then know what those key elements ties into the diagnoses. So studying the conditions, kind of taking ourselves back to actually spending time on dental diagnostics, like what are the typical oral pathologic conditions? Or how does a person's medical history really affect what we're going to do? Or what type of pain-related complaint is this? Is it really a joint-related issue? Is it arthritis? Is it myofascial pain? Learning just a few key differences in how to differentiate those conditions, that will help you get to a better diagnosis. And then the treatment, you're right, is simple. It's easy. But getting the right diagnosis is hard. And it doesn't come right away. There are so many times, even today, I will miss a major diagnosis, like, for example, trigeminal neuralgia. That's a tough one. Sometimes you get secondary muscle and joint pain from that nerve pain. So I'm treating somebody for a TMD, and then later on, that neuralgic pain unfolds itself. So we'd have to take our time with these patients, kind of let the story unfold, but be conservative in the beginning and just know the major categories of pain. And
if someone wanted to learn more about the diagnostic side, what tool would you recommend? Is there a textbook, a course, online? What?
Absolutely. I mean, there's many courses. I myself give these courses in town and around the country. But I would say if anyone's interested in oral-facial pain, the oral-facial pain guidelines and assessment that's published by the American Academy of Oral-Facial Pain is an excellent first initial.
That's a book?
It's a book, yeah.
What's the name of the
Oral-facial pain guidelines and assessment, something like that. I can always get you the right
from the American Academy.
But it's published by the American Academy
of Oral-Facial Pain.
And then there's one more that's really.
And let me So what was the name of that? Should it just be on their website?
It should be on their website. Yep, under publications. Mm-hmm.
Okay, so American Academy of Oral-Facial Pain, that's AAOP. Wow, that's .Club Express. Did you see that? That is an interesting website. AAOP.clubexpress.com.
Is it really? Yeah.
There's been a whole bunch of Okay, so professional resources,
Yeah.
and it would be called, I wonder. Yeah, if you could email me
I will
that,
email you
I'll
that.
put it in there.
Absolutely,
But
yeah.
you say it's a textbook?
Yeah, it's a textbook.
Do you see
Yeah,
it? You see it
actually-
on their site?
So let me help you here. Yeah, this is it.
There it is. I have so much respect that you can use that little
Oh, the touch
mouse in the middle. My boys are always trying to get me to use that thing. I'm like, no, I have to have the old.
I still use that for the most part. It's
old mouse.
okay.
So you're pointing to the Orofacial Pain Guidelines for Assessment, Diagnosis, and Management, 6th edition. So that's a $56 book from Quintessence Publishing, and that's that's what you like the most.
It's a great start. It's a great start for anyone who's interested in orofacial pain. Then there's also Dr. Glenn Clark helped write a book. It's called Pharmacology in Orofacial Pain.
Pharmacology and Orofacial.
It's a bright orange book. You can't miss it. That is excellent.
Do you want to find that for me now, or do
I
you
will.
want
I can find it for you.
Okay, let's. Is that on the same website?
No, that one we probably have to.
Because these are simple subjects to learn, and the one thing I have to say is what I don't understand about young millennials. They complain about their student loan debt. They complain about everything, and then every time they want to learn something, they fly clear across the country in an airplane, stay in a resort, drop $1,000 on a course, and then here's this $56 textbook that you couldn't even have read in the entire weekend. My go-to is always a textbook.
I agree. I'm traditional when it comes to that. I need my textbooks.
Yeah, and I've my boys. I remember one time my boys. They counted them. Dad had 1,000 textbooks read.
Wow.
In my office, and they were just saying that. It used just to blow their mind, and I would just sit there and think, well, if you really want to learn something, God, isn't the fastest, easiest way to learn it always going to be a textbook? I
agree. I like having the textbook, then I'll go back and read it again or look stuff up. There's a lot of resources out there too. You just need to know
it's kind of
find.
annoying when you go to somebody's lecture and the questions are just like, dude, that was in like the first 3 pages of the first chapter. How? Yeah, you know what I mean? It's like if you just. My God, if you just read the advertisement for the book on Amazon, you would even ask that question.
That's too bad, though. That you would feel, you should be able to learn something new, I think, in a lecture.
So on diagnostic dentistry, you recommend those 2 books? That would be the starter?
For orofacial pain, yep.
For orofacial pain? And then what else?
Well, I like for oral medicine or medically complex, there's the Little and Felice book of the dental management of the medically complex patient. Most dental students should get that through their university. And then Burkett's oral medicine.
Actually, will you just send
I will send you a list.
You send me a list of those books, because what I'm trying to do is make everything faster, easier, higher quality, lower costs, and
sure.
4 $50 books is something that everyone can do. But going to some of these institutes that are $3,000 a weekend is, I can do them because they're fun and we're older and we have that money. But some of these young kids, or they're in a small town, they have they're playing. They got the mom hat, the dad hat on, so they got to practice. They got a lot of debt. They got kids at home, and I don't know. I would just read it first. I think reading is so much more faster. So my question is, there's 2 things I don't understand in dentistry, and is why anybody would want your job or a pediatric dentist. How did you look at everything you could do in dentistry? Like when you tell me you want to be a pediatric dentist, my first thought is, what went wrong in your childhood where you woke up one day and said, I just want to listen to a bunch of babies screaming and crying. So why?
Yeah, why did I do this?
What attracted you? Was it because pediatric dentistry wasn't painful enough? Did you try to one up the pediatric dentist, or what happened?
I'm telling you, no. Like I said before, this was an accident. Honestly, I went into dentistry. So let me take you back to my high school days. I always wanted to be a physician. That's what I was going to be. Then I entered junior, senior year. You apply to those programs. I thought, let me apply to these fast track medical school programs so that I don't have to, I don't have to be afraid I don't have a seat in medical school. And I did get into one of those my senior year. But I realized at the time, it was almost like, I know it might sound a little cheesy, but it really was. I feel like what you're meant to do, you're going to do regardless of what's happening. So my heart was not into medicine, nor was it moving all the way across the country to this program. So what happened then is a few people around me started talking about dentistry. My dad's a dentist, though I never considered dentistry despite the fact that he's a dentist. That then kind of just sparked an interest saying, hey, I really like this field. It's procedural. There's also a lot of diagnostics in it. This is fun. So anyway, I said, okay, that's what I'm going to do. And then I don't look back. I say, this is what's me. So when I got into dentistry, I didn't even know what a crown was. I mean, I'm just being transparent here. I really didn't know. I was very young, very naive, and didn't have a lot of experience in dentistry. I loved every bit of it, but I loved the surgical skills. I loved the hands-on procedures. But that little bit in the back of my head said, hey, I still don't feel confident that I know all these about these diseases people report today when they show up as a new patient. How do I know if I'm treating the patient the right way if they have such and such a disorder? And then I got more involved in academics. I always knew I wanted to be a part-time academic, maybe involved in research. And one thing led to another. Let me tell you, my initial thought was oral medicine. And I just kind of went into it thinking, you know what? I don't really want to go into practice right away from school. I want to do something more. So let me take some time to grow as a professional, and then I'll enter the practice realm. So what happened was I thought, at the worst case scenario, I'll just learn a lot about oral medicine, and then I'll go into general practice when I come out. I got into oral facial pain completely by accident. That I didn't even know what oral facial pain was. And I'm going to tell you, it was challenging the first few months. I was a little bit of a shock as to what did I get myself into? But now I'm looking back and I thought, wow, I didn't even know that dentistry could involve these aspects. And it's been the greatest growth ever.
And that was at USC?
Yeah.
And that's in LA?
It's in, LA, Los Angeles, yep.
Was it you lived in Phoenix? You lived in LA?
No, I lived in LA for 2 years after dental school,
Do you wish you were in LA? Or
That's a good question. People ask me that. I really enjoyed my time in LA. I really did. But I do remember 7 years ago that I was itching to come back to Phoenix. I love it as a city. There's so many things to do. Great people, great academics, great culture. Traffic, it's a little congested. To me, Phoenix looks like a mini replica of LA. So I love my hometown, which is Phoenix.
Yeah, I have the hardest time leaving San Diego.
Well, San Diego's a whole different ballgame. I agree. That's a nice place.
But I feel like Airbnb. I mean, I'm a big Airbnb guy. I mean, you can get anybody's mansion on the beach for almost no money. Really. I mean, I got a lot of kids, and I got 4 kids and 5 grandkids, and God, you can get some of the nicest $1 million houses. Anywhere from San Diego to LA on those beaches for just a couple $100 a day. I mean, it's just so that's why I would never buy anything over there. But yeah, I love that area.
Yeah, it's amazing, all of it, for sure.
So you are glad you're doing this, and
yeah, it's the best thing that ever happened to me. I think the high school side of me that wanted to be a physician, I get to use some of those skills that I didn't realize you could use in dentistry. So I get to kind of keep both, is what I feel, and I love it.
Yeah, you say you like speaking. Yeah. If someone wants you to speak at their group, how do they contact you? Do you have a website for that?
I do have a website, but most people contact me by my email, just directly,
and
or my office email. But
so how do you want? Do you want to tell them what that is?
Oh, absolutely. My email is sbpatel. So it's my initials, S as in Sam, B as in boy, Patel, Patel at
Your middle name is Boy? Your dad is a practical joker, isn't he?
It's at AT. So sbpatel at atsu.edu.
Okay.
Yeah.
And what do you like to lecture on? What is your classes called?
So I started doing a lot of speaking a few years ago, and it's evolved into kind of a variety of courses. Most of my lectures are on oral facial pain subjects. So that could be pharmacology. I can do 1 to 2 day oral facial pain subjects on kind of the whole scope of it. Hands-on workshops on injections, things like that. I also lecture on oral pathology, so oral mucosal diseases. I'm starting to lecture on sleep, dental sleep medicine. Head and neck cancer patients is another great topic I love to talk about, so I do that. Cancer and oral health is another topic. So,
and is pharmacology over the years, is pharmacology being more of a tool, the same, or actually less?
You know, actually, most orofacial pain providers will tell you that it's becoming less. But I think it's just important to know what tools we have. So most people can be treated with physical medicine modalities, orthotic therapy, and some lifestyle modifications. And we use medications for a short period of time. However, there are some chronic conditions or neuropathic conditions that just simply require medications. So I'd like to go over at least what that is so we have the exposure to it. I also go over injectables. That's part of pharmacology too. So I love injections in our field. So the interventional treatments. And then the oral medicine aspect also requires a certain expertise in pharmacology. So I like to train people on that.
What are the most common pharmaceuticals?
For oral medicine? For oral medicine, chronic diseases are usually immune mediated. So my first line medications are topical corticosteroids. But most of the time, we don't get them to the right medication or the right potency and the frequency. And then how to manage the side effects. Most people feel a little uncomfortable as to how long a patient should be on a topical corticosteroid. And then you can also inject corticosteroids in the lesions, or then turn into immunomodulating therapies too. So, but first line,
and what are
steroids.
common lifestyle choices that?
Well, when we're talking about orofacial pain disorders, lifestyle modification is huge. I counsel patients every time I see them on making sure they have appropriate posture, relaxed posture, the tongue goes to the roof of the mouth, keep your teeth apart, learning how to stretch the muscles properly, even taking some relaxation classes or seeing a counselor who can help them with that, or try things like yoga, low-impact exercise, tai chi, meditation. These are all wellness techniques we should incorporate. And then, of course, softer food diet for certain joint-related conditions, or avoiding things, harmful habits. Becoming self-aware of those things makes a big difference. Becoming more disciplined, sleeping well, things we should probably know already, but yeah.
And how much of this is because of chronic events versus acute? Like I wrecked my car, fell off my bike.
I will say in my practice, I probably see a much higher percentage of chronic. And there are several reasons that can happen. And perhaps the acute issue wasn't treated adequately and then turned into a chronic problem. Perhaps there's other systemic diseases that make this person more susceptible to chronic pain. But I think that most primary care practices, including general dentists, will see acute. And that's actually why the percentage of TMDs is about 12% in the general population. How many of those actually make it into the office is probably a lot fewer, because most of these resolve on their own. So that's why we don't jump to intervention too quickly, because we know that give this some time, perhaps a short-term course of medication, thermal therapy like heat and ice use, watch it for a few weeks, and if it doesn't get better, then start treating.
They say only 5% of Americans will ever see a chiropractor in their lifetime.
Oh.
But everybody will see a dentist. What percent do you think will have oral facial pain?
Well, generally the statistic is about 12%.
12%?
Yeah, so it's pretty high. Yeah.
So it's basically 2.5 times the chiropractic industry.
Yeah.
So
12% is probably the amount affected. Let's see if we're talking about how many get seen. I don't know. Maybe I would cut that in half. That's hard for me to answer. I'm not too sure. Yeah.
Well, it's really interesting. I mean, and then when you get to the very richest 20 countries, there'll be 5 physicians for every dentist. And then by the time you get to the 50 poorest countries, reverse, there'll be 5 dentists for every physician, because in a very poor country, you're not going to get treated for, prostate cancer. But you will find a dentist for a toothache. So the dentist is the number one.
Yeah.
I mean, you're going to see them. So probably that everything I've read, everyone's going to see a dentist.
Absolutely.
In their lifetime.
Well, there are studies even in when we're looking at the HPV vaccination subject. They've seen that they've actually counted, like, you almost see 1 million more people if we include dentists in discussing the HPV vaccine. You could target a lot more people, because there's children who visit dentists more than physicians.
I know the dentists aren't going to do this, but I mean, I kind of want to be the first Jimmy Hoffa of dentistry. I mean, I can't give a flu vaccine
I
So
know.
so here's grandma. She's more likely not to come back in 6 months, dying from pneumonia in the winter. From I mean, a couple of winters back was a 38,000 death winter for the flu, and I'm not allowed to give a flu vaccine. I can't even buy an HPV vaccine for me. I mean, and then, like I say, the lady I bought my house from had to leave the country to go get a medication that was made in America. Do you think that's going to change in your lifetime?
I do actually, yeah.
You?
Oregon has already changed their scope of practice to include those things. So that
Oregon, you can give a flu shot?
Yes. They can give
Really?
any vaccine. Now, the issue is whether it's covered or can dentists be reimbursed. That's another barrier.
Yeah, and that's a whole other question.
Yeah,
I mean,
the scope of practice has changed. That was just April of this year. And so that's a huge barrier broken if more states could follow that model. So I think it will happen in our lifetime.
And it's tough because I mean, I love my physician, but I have to tell him several. I mean, you ask him a question, the first thing out of his mouth is always, "Well, I don't know if the insurance," and it's like, come on, dude. We've had this conversation every time I have a job. I can pay, same thing at the Walgreens.
True.
Like, well, the insurance, I said, I didn't ask about the insurance. So I
Yeah.
know that's a totally separate subject. And that is the most important element to probably half of Americans who's
Right.
going to pay the $100 for a vaccine, because half of Americans, they have $100 to go buy a pair of Nike tennis shoes. But anyway, but yeah, I think those are just big challenges. I mean, I just want to see the day where I have enough freedom to give a flu shot that the pharmacy tech at Walgreens can give, and that went to a 9-month training course, and they can give the HPV vaccine if somebody checks it off, and then give a flu shot. But Dr. Farran can't. Nope. 9 years of college was not enough. It's probably because I went to ASU. Probably. And they know I went to ASU, and that if I would have went to U of A, maybe
May make a difference.
So why did you go to U of A? Because instead of ASU, because what I've noticed is that kids just want to leave town.
Yeah.
It seems like everybody in Arizona goes down to Tucson U of A.
That's exactly
and everybody at ASU is from Tucson. Well, was U of A, was your primary reason just to leave town?
Uh-huh.
Yeah.
Yeah, I wasn't so keen, nor were my parents so keen on me going really far away at that time. So, and also just there were a few other factors involved that, with my goals in life that aligned the best. But yeah, the most between ASU and U of A, I did go to Tucson so that I could leave Phoenix for a few years.
And we went over an hour, and I can't believe that hour went by. But of all the things you listen, you said you love orofacial, you love speaking at conferences, giving CE courses, teaching, research, publishing, traveling, and spirituality.
Yeah.
I'm looking at this list, and
I know it's
the last
random.
word is spirituality. Where did that come from, and what does that mean to you?
So, I think I've always kind of been interested in that phase of life for years, probably 10 plus years now. I think it allows me to stay calm and look at the big picture, because with all of the responsibilities that we have day to day, and God knows every year it just gets more and more, I almost find that struggle in terms of taking a step back and truly relaxing, knowing that how can we maintain this bigger picture in life and really realize what its purpose is. But really, this is all just selfish. I need to figure out a way to stay calm. And that's something that we just get so busy in our lives that it teaches me to appreciate.
And what does
things.
Spirituality mean to you? Does it mean organized religion? Does it mean...
Not necessarily.
What does it mean to you?
Looking inwards, but learning more about yourself before anything on the outside. Because if we can control our inner selves and our emotions and attachments, then that's what's going to translate automatically to the outside world. And that's how we can achieve what we want and do what's best for everyone around us. So it's trying to keep that clarity, or I guess achieve that clarity. That's what it means to me.
I think that's an interesting... I've never heard anyone describe spirituality as looking inward. That is because most people associate religion as some organized...
Yeah, I think things are
textbook,
changing, yeah.
And you're seeing it as more a self-awareness.
Absolutely.
Inward looking. That's a really neat definition of spirituality. Yeah, I love that, because everybody is so quick to backseat drive everyone else's job.
Yeah.
And it's like, if everybody could just manage the person in the mirror,
that's all you have to do.
That's all we'd have to do. I mean, there wouldn't even be government or military. There wouldn't even be a police department if everybody could manage themselves. But it seems like the more I hear a person backseat driving, how that person's not doing it right, and it's like they always are smarter than the president of the countries, Fortune 500. They're smarter than all these organizations, and you're like looking at their own little upside down dental office that's running backwards and thinking, maybe you should just focus on your dental office.
Yeah.
And you weren't there to figure out what, I mean, like Apple's made some just incredibly bizarre decisions. But my humble self always thinks, well, I'm sure they had meetings that I didn't get to attend and discussed events that I'm not aware of.
Yeah.
And just maybe there's more to it than that. But love what you're doing. Would love to have courses on these blocks. I mean, I bet there's so many dentists out there that never even seen one.
Yeah, that's true. They're popular. I do. Yeah, they are. But, people are interested, which is encouraging.
And how is it? I keep saying last but not least, but how is it? Do you have fun at AT still?
Oh, I love it. Yeah, it's a great environment to work in. The people I'm around, the patients we see, the residents, the students. I can't say enough good things.
I love the two Tims over there. Tim Lukowski, Tim Taylor.
Oh, yeah.
Are they the life of the party
people.
always?
Oh, yeah, absolutely. I work with Dr. Tim Lukowski twice a week. So we work really closely. He's a wonderful human being.
I've known him since Creighton University.
Yeah.
What an amazing man.
Yeah.
Seena, thank you so much for driving down.
My pleasure. Thanks for having me.
And tell your dad that I said he did a very good job with you. And tell your dad hello and thanks for all he did for me 30 years ago.
Thank you. Thanks for having me.